Good morning. It's Alejandro Badia with another bi-weekly episode of the podcast, Fixing Healthcare from the Trenches. I am very honored today to have a real leader in the healthcare, particularly the orthopedic healthcare investment banking community. And this is Hector Torres, who's here in Chicago. So Hector and I met at a physician transaction conference, pretty much focused on orthopedic transactions. And since I happen to be in Chicago here for the Becker's Healthcare meeting, which is an amazing meeting, by the way, I said to Hector, let's try to meet and let's do a podcast together, talk about really what the issues are facing healthcare. So Hector's background is interesting because we both went to school in Western New York. We had a lot of time to study because he was at Syracuse, I was at Cornell. Terrible weather, right. No good restaurants.
Very conducive to study.
That's right. And I went to law school there, right? And he got a business degree there in law school. And he was in a boutique healthcare investment banking that was now acquired by a very big company that has multiple offices there. And he'll tell you about it, based in Japan. And we've been talking about certainly the orthopedic urgent care landscape. So, but moreover, this podcast, as we all know, is really a bigger charge, which is really how can we fix healthcare in the U.S., which is now approaching 20%. So I'll let Hector tell you some of the exciting things he's working on.
Thank you, Dr. Badia. Pleasure to be with you and to be here at the Becker's conference in Chicago. My name is Hector Torres. I'm a managing director with DC Advisory, and I cover our healthcare services and healthcare provider coverage efforts on behalf of the firm. And really, our mandate is simple when we boil it down, which is to really be a resource and a true advisor to our healthcare clients, and in particular, our physician group clients that are looking for access to capital and strategies to really be able to change the paradigm in healthcare and ensure the sustainability of their practices, but ultimately ensure the sustainability of best-in-class patient care, which is obviously what we all aspire to do. So it's a pleasure and a privilege to be here with you.
Well, no, absolutely, because I think that most physicians have to realize we don't have a business acumen. Most of us don't have now many of the younger ones are getting MBAs, and I applaud that. But the reality is that it's just we're not trained in that, and I truly believe to fix healthcare, we need to have partners who understand the financial part, the regulatory part, the legal part, and as you know, there's been a fair amount of trepidation, maybe even backlash against the private equity world.
Yeah.
So I'd love for you to address that for our listeners.
Yeah. Well, it's a great way to kick things off. I like it. There's a lot of depredation, and I think there's a lot of what we call negative fantasies, right?
Okay.
And I think that those negative fantasies are rooted in some basis. I think it really stems from the 1990s and the FICOR era, where a lot of physicians and the business community at large partnered in ways that weren't necessarily aligned among themselves.
Okay.
And I think importantly, in ways that weren't necessarily aligned to delivering patient care in a best-in-class way. The market evolution from that late 90s period to today has transformed. To say it's changed would be insufficient in terms of just the dynamic element of where we find ourselves today. Today, private equity is more relevant and prevalent in healthcare than ever before, because to your point, healthcare represents almost 20% of GDP in spend, and it's fraught with inefficiency, right? Highly inefficient. And their mandate is to help enable growth and success and address some of those inefficiencies with a variety of means, right? Obviously, they bring a lot of capital, and with capital, you can do a lot of good things. But they also, I think, bring a lot of administrative and management expertise and support that is very much needed today. But look,
so economies of scale and efficiencies. Where yes, one of the misconceptions, right, is that we're going to be told or even influenced about how to practice healthcare. And I think certainly if you're doing it in an efficient and overly costly manner, that'll be pointed out.
Yes.
But I don't think my understanding, what I've spoken to most colleagues have said that no, our partners in that are not stepping on our toes and want us to do the best thing for our patients, which ultimately saves money, right?
That's right.
I've always said that. I mean, good healthcare is actually very thrifty healthcare.
Yes.
Actually.
Yeah. That is the biggest negative fantasy. Right. The thought that someone that may look and dress like me in a very
which is very good, by the way.
Thank you. I agree. Well, same to you. But all joking aside, the concept of someone in a tall building in New York City is going to be calling me on a Tuesday, telling me how to practice medicine. The reality is that doesn't happen for a lot of reasons. Legally, it cannot, right? But structurally, it doesn't either, because in a lot of times we structure our deals where we're representing the physicians, whereby clinical autonomy is preserved in perpetuity, meaning it doesn't matter whether you have a private equity partner today or you end up having 15 of them down the road once you've partnered with the first one. The ability for the physicians to control every singular aspect of the practice of medicine is paramount, right? And if there's a private equity firm that wants to deviate from that model, well, it's probably not the right private equity firm, and it's probably not one that's well-versed in this.
Well, they're probably not going to last, right? Because and there are PE firms and even orthopedic MSOs, right? Yeah. So maybe even tell our viewers, or maybe not our physician viewers, but the public, about what MSOs are and what they bring to healthcare.
Yeah, MSOs are the management services organizations that really act as the administrative support and infrastructure for these PE-backed physician platforms, and in particular in orthopedics, it's been explosive. In the last 5 years, there are no less than 20 private equity-backed orthopedic and musculoskeletal platforms, and growing, because orthopedics is obviously a high beta area, right? It's very sexy in terms of the surgical composition of the services being delivered, but also the ancillary services. Think of DME, imaging, surgery centers, orthopedic urgent care,
and that's what this meeting is about. So for the public to understand, Becker's healthcare, which has multiple meetings a year, this one is strictly about ambulatory surgery centers, and the core message here is that you can do many of these surgeries. Certainly, let's just talking about orthopedic or musculoskeletal. I haven't done surgery in a hospital in a decade, 10 years at all, not one case. Right. So, and I think intuitively the public is starting to understand that if you can do a surgery, have a procedure in a place that isn't a big hospital, obviously it's going to be less costly. We learned with the pandemic that you don't have to worry about being at risk, right? Not just with COVID virus, but there are bacterial infections, and it's very costly. And that doesn't mean we don't need hospitals, obviously, but for a lot of what we do, the advances in anesthesia, in the technology,
imaging, everything.
So
robotics.
I just attended a robotics seminar with a colleague actually from Broward County, who's doing some amazing things with outpatient joint replacements. So, but we have to, my colleague and I have to focus on that, right? The medical part's hard enough.
Yeah.
We need partners.
You said something powerful. You haven't practiced medicine in an inpatient setting in over a decade.
It's incredible. Right?
I think in a decade, there will be orthopedic surgeons that never, ever enter the acute care setting, meaning they'll never have performed a case in that setting of care. The acute care hospital is very relevant, right?
Yes, absolutely.
But it's not relevant for everything, right? And I think that trend will
grandma
continue.
breaks her hip. She's got to go there. She's got to, but for much of what we do. So speaking of, we in terms of healthcare, I mean, I have certainly my ideas, and I'll share those. But I mean, what would you say are three of the top initiatives? You're seeing it from the private equity point of view and the business point of view. I mean, what three initiatives would you say we can implement to fix healthcare?
Yeah. Wow. You're starting with the easy question.
That's right.
Huh? Look, there's so much. The system is so big. And as we mentioned before, it tends to be very inefficient in a lot of ways, operationally, strategically, clinically, financially. But I think if we really anchored on three elements, I think the first is preventative medicine, right?
Wow. Okay.
How do we think holistically about a continuum of care, and how do we educate the patient to prevent a lot of the incidents
and the chronic disease, right? Which we know, diabetes, obesity, hypertension, all of those things. I see Dr. Redler here. One of the beauties of doing this podcast right here at the Becker's meeting, Dr. Redler is an alum. Michael Redler is a surgeon. And come over here and say hello. This is live. So Dr. Redler's
Hey, Dr.
Hector
Redler,
Torres.
good to see you. How are you?
All right, nice
Pleasure.
to see you.
So he's talking about preventive health. Come on in here so we can.
All right,
So Dr. Redler, about a month ago, 3 or 4 weeks ago, he was on.
Yeah.
He was in a hotel room.
Yeah, I remember the episode.
we
Great,
did it.
good
Yeah,
one.
yeah.
You know, and I got to tell you, the lighting here in this lobby is way better than a hotel room. So apparently, you're of such great importance. You get pretty good light here. So this is obviously, in terms of talking about preventative care and medicine.
So that was his first. So that's his first initiative.
Yeah.
So preventive care, obviously, I mean, huge. That's the whole notion of healthcare, not sick care, right?
Exactly.
Not being reactive. Okay.
Exactly.
All right. So number two.
Number two, I think variability is the biggest cost driver in healthcare, right?
Oh,
Really
interesting.
fascinating.
Okay.
In a different life.
That brings us back to transparency, right?
Yeah,
Cost. Okay.
yeah. I worked in private equity for 6 years, and we owned a medical device implant company, right? And I was fascinated by the concept that when we looked at the same surgical procedure in New York, in Austin, and in Beverly Hills, completely different costs, completely different
Sure.
reimbursement, almost a completely different procedure in every single facet. Why is that?
No.
Same patient population, same clinical.
Well, because
indication.
healthcare is very fragmented. So, and in those same markets.
Thank you, Dr.
And it's
Thanks
awesome.
for
I'm
joining
going
us.
to get out of your picture because these are some high-level questions and obviously some high-level
Listen,
answers.
a leader in the ASC industry. I mean, bringing
Nice to see you.
Absolutely. Thank you, Dr.
So certainly variability.
Right, but even within those markets you mentioned some cities, right? So you know that I've been for the past almost a year. I'm doing some surgery in New York, my old stomping grounds.
Mm-hmm.
Those costs are going to be very different where I'm doing surgery, which is the shout out to the Gramercy Surgery Center, right? They're ranked the number 1 ASC in the New York market for the past couple of years. But those costs are going to be very different there than in an excellent institution, which is where I trained, which is NYU.
Yeah.
But it's a big, expensive hospital.
Big-
So those costs are going to be different.
Big academic medical center, which
Right.
is even more
Right.
expensive. No offense, but
Right, it's true. Well, we have.
yeah.
Yeah, we have. I mean, you don't need to have your. Speaking from me, you don't need to have your carpal tunnel, or frankly, even your rotator cuff done in such a big institution.
Correct.
Right, and I think everybody has to agree that we have to get meat in the sandbox and reapportion these things.
yeah,
And so the big hospitals, of course, are starting to open more and more surgery centers, but they've got to make sure that at a reasonable cost.
yes.
They can't be at the same cost as a big hospital.
That's
Doesn't
right.
make sense.
And that's a great segue to my third element, which
Okay.
is conceptually alignment of incentives, but it really is value-based care. Really, how do we incentivize and align ourselves to deliver the right patient care in the right setting of care at the lowest possible cost without burning out our physicians, right?
Well, yeah, the quadruple aim, right?
The quadruple aim.
Now, let's dissect value-based care, because the problem is many times things become a cliche,
Yes.
right? So we hear that all the time, value-based care, and the struggles I've had with trying to bring orthopedic walk-in centers, which is completely intuitive, to big, whether it be healthcare systems or even companies that are trying to transform healthcare delivery, right? Shout out, Know Me Health is here.
Yes.
Very focused on employers.
Yes.
Now, so obviously what we're doing is, you can call it value-based care, but the public needs to understand what that means.
Yeah.
And the payers need to understand what
Yeah.
that means.
And the thing about it is it's become a cliche of
Yes.
itself in many ways, to your point, because it's not a one-size-all model of care.
Right.
It can be episodic. It could be full continuum of care. It could be full capitated risk. At the end of the day, healthcare is still very local, right?
Yeah.
At the provider
Very
level, at the
regional,
regional
very-
level, at the super regional level. Value-based care is only relevant if it's creating value for your patient population at the local level, right? So that's going to be very different. But at the end of the day, you have to be incentivized to deliver the right patient care in the right setting at the lowest possible cost, and have the insurance company be an ally and a partner in ensuring that outcome.
Instead of an obstacle, which is, we'll get to my three.
Yeah.
So absolutely, instead of an obstacle. Absolutely. I mean, and the frustrating thing is, and I wrote, which I think you're almost through, right?
Almost
Healthcare
through.
from the trenches. But healthcare from the trenches, pointing out the problems. Admittedly, wasn't the visionary who said, I'm going to write a book and bring more solutions.
Well, that's the next book.
Well, if I still have it in me. But I will tell you, there's really bright people out there doing that. And I'm reading now the second of two books that Zeev Neuwirth has written. So reframing healthcare. So I met with him here at Becker's. He gave a fantastic talk. And he's mentioning all of the players that are out there doing this. And I could relate to this because I've been doing ortho now for 13 years.
Yeah.
There is, for example, a company doing a hospital at home.
Yes.
Right. I mean, think about that. Unless you need an ICU and that kind of in-depth monitoring, you don't necessarily need to occupy a hospital bed.
Yep.
Obviously, I understand the hospitals may not like that because they've got but we're all going to have to shift.
We're all going to have to shift, even physician groups, even the larger scale
absolutely.
physician groups. And not to be too controversial, but my vision is
this is a place to do it.
Exactly. It's, we've seen the evolution of the migration from the inpatient to the outpatient setting
Yes.
of care. And then we've seen the evolution from the inpatient setting to the clinic-based setting. The next evolution is clinic-based setting to in-home setting.
In-home with wearables,
Yes.
right? With technology,
Yes.
which is out there, but not being really adopted. Look, I got an email today from a colleague in the therapy area who basically told my team, well, I'm not sure I can't promise that the app is not going to be adopted. I'm thinking, wait a second, if I told you about an app for wine, you would download it immediately.
I would have
right?
told you I already downloaded it.
Right. So here is, a wine app, a food app, a dating app, right?
Yeah.
I mean, people immediately, assuming they're single, hopefully, right, will immediately adopt that. But yet I tell them about an app. So as an example, Ortho Now, the app says you can let us know when you're on your way, on my way now. You can call an Uber or a Lyft, right? Another disruption. You can call it Uber or Lyft in the app. You can tell us what time you're going to be there. You can send a picture of your injury if relevant. And then the clinicians communicate through the app about your clinical problem. What more? And yet people, even in the healthcare, are still pushing back, right? So the question is, when are we going to really open our minds?
Now, if
and
we told the patient, whatever your out-of-pocket costs are, if you use the app, they'll be 50% less. I think they'd use the app, right?
Yes.
So
and
that's
right.
where every constituency in the system, the insurance payer, the payers, the providers, they have to align.
Right. Well, that's the problem. My previous CFO said that. He said, one of the things, he came from a completely different industry, and he made an excellent point. He says, healthcare is one of the few industries where the incentives are not aligned.
No, and sometimes they're perverse.
Right? Well, yeah. Well,
They can be perverse.
I just had an article. I'm not sure you saw it about the medical loss ratio. Right? That's a perverse law during the ACA, right, Affordable Care Act, that said an insurance company has to spend 85% of their money, their earnings, on delivering care. And you say, oh, that sounds great, very noble, right? Okay, pay your people with 15, but there's a perverse incentive there that if they save too much money, then they're out of whack.
That's right.
So that has to be repealed.
Exactly.
So question is, how can it be repealed if in the first two Republican debates, healthcare was not even mentioned?
Shocking, right?
Shocking.
Yeah.
So here are my three. All right, and in line with yours. One is we need oversight, not authorization. Right? Why should a physician who's the best trained person to decide, and not just a physician, right? Mid-levels are a valuable part of our treatment armamentarium. So a nurse practitioner experience and an orthopedic PA. If they say that this test is needed, why should we have to get an authorization from somebody sitting at a desk who doesn't understand it? That person has a salary and benefits.
That's right.
Right? And they slow down the process, and time is money. And in the healthcare, it's not just time is money, is a tumor is being missed or a joint is getting stiff, right? So that's one. Two is a patient education, public education, which is why we're doing it, right? You're taking your valuable time to do this because we care. We want the public, not just practitioners, not people in the healthcare finance industry. We want the public who consumes healthcare to understand the problems.
Yep.
Right. And the last one is very important, is a right clinician at the right time. That saves money. was it in the 80s, Hector, where we started pushing the gatekeepers and telling our overworked primary care colleagues that they had to see everything and give an approval.
Mid to late 80s.
Yeah, that was a terrible idea. Yeah. I mean, you're taking a very busy person who's supposed to be keeping us healthy, monitoring chronic disease, making adjustments, and then telling them, in my case, a shoulder specialist, that they had to see them first before they could see me for shoulder. I mean, they're not trained in that. Why? And then they're going to send a bill, right? So now the insurance company is paying a bill for the primary care doctor. Then maybe the general orthopedist, and the general orthopedist says, you know what? I really do more hip and knee. So now you got to go to this crazy guy Badia for your shoulder. Yep. And now we spent money.
And how frustrated is the patient?
Oh, terribly.
And well, how much pain is that patient in?
So here's the question, Hector. How frustrated do the public have to be before they step up and talk about this, whether it be social media, as we did with racial injustice, as we do with Save the Whales years ago, right? I mean, this is a movement that has to come from the public.
I think it's a movement that needs to come to your point, and it has to be driven by the patient. Right. Because the patient's the one that votes, right? Right. And the patient votes with their feet, right?
Absolutely.
And I think from the highest office in the land to the most local office in the land, this has to be an issue that's being driven by the patient from an advocacy and prioritization perspective.
Well, so ending with that note, whoever's watching this, if you think this is interesting, you know, we love likes and all of that, but no, we want you to share this and talk about it and critique us, please. There's nothing better than somebody writes me and says, I think you're wrong about this. Fine. But engage, care, and that's how we're going to change it. And I look forward to doing more work with you, maybe business, and bring in a better orthopedic care to the public.
Thank you for having me.
Thanks for your time.
Thank you for all.
Thank you.
Thank you.
See you in 2 weeks.